Go for it, Annie.
Okay.
Take it away.
Yeah. All right. Hi, everyone. I'm Annie. I'm one of the R3s in our program, and I'm giving a talk today called Health Equity in Viral Hepatitis. So I was originally going to give a presentation called the ABCs of Hepatitis, which would have been this very comprehensive review of all of the clinical information you need to know about hepatitis. But in working on that, I found that there were a lot of health equity issues that affect patients who are vulnerable to viral hepatitis. And that started to seem like a much more important way to frame this presentation. So we're going to practice talking about systems that are preventing equitable access to care for certain populations and individuals, while also touching on some clinical pearls and epidemiology. No disclosures. My objectives include that by the end of the session, I want you to be able to manage hepatitis A in the outpatient setting, articulate how hepatitis B is transmitted, be able to explain to a patient the expected treatment course for hepatitis C, identify populations most vulnerable to hepatitis A, B, and C respectively, and employ a framework for thinking about systems that prevent equal access to care for certain groups or individuals. So as our agenda, first I'm going to go through a definition of health equity and then introduce you to the framework we're going to use to talk about health equity issues. And then I'm going to introduce a case for each hepatitis. And for each of those, there'll be some questions, and I'm going to have you just answer those questions either with a pen and paper or with like a notes tab on your computer. So just answer it for yourself at home. It is helpful to the educational process to actually get it out of your head and out into the world somewhere. So I'll give you, in a minute, I'll give you some time to get your paper together. And then I will review the clinical learning point, and then we will practice using the health equity framework together. So I like the Robert Wood Johnson Foundation definition of health equity, which reads, health equity means that everyone has a fair and just opportunity to be as healthy as possible. So when we think about this word healthy, I think when we think about a healthy person, that rarely has to do with their healthcare access or how good their doctor is. It has to do with their access to food and exercise, and those things really rely on having a safe place to live and a job that provides economic security and a supportive community. So I want us to be thinking about equal access to all of those social determinants of health as we move forward today, and about the obstacles that prevent everyone from having that fair and just opportunity to be healthy. And one way to think about that is with this framework, which is called the social ecological model. And it's a public health tool that is used to think about what influences someone's health. So we are all individuals within interpersonal networks and organizations that exist within a larger community or society. And that community or society is shaped by policies and laws, or influenced by policies and laws. And to give you some examples at each level, so on the policy standpoint, there are local, state, and federal laws. Communities have social, political, and economic forces that shape them. Organizations can be workplaces, religious groups, schools, healthcare systems, and they have their own policies and norms. And then interpersonal networks can be families, peers, social networks, and individuals. We all have our own knowledge, attitudes, beliefs, and behaviors about our health. I think this can also be helpful in thinking about root causes when we think about, individual behaviors. We can kind of go up the chain and think about what are, forces within a community that influence that individual behavior. What are policies and laws that are contributing to that individual behavior? So for each case, I'm going to ask us to think about factors at each level of this framework that might prevent equal access to health for the population in question. And I am going to ask you to participate by either unmuting or more likely saying in the chat your ideas. I can't see the chat. And we are going to be talking about vulnerable populations and minority groups and whose experience we might not share. And that does put us at risk of unintentionally making biased statements or generalizations. So I want us to be willing to name that if those kinds of statements come up, while acknowledging that we're all going to make mistakes as we practice talking about health equity issues, and that's expected. But one way to avoid making generalizations is just to speak from one's own experience. So to start statements with, when I worked with a patient from this country, I observed X, Y, or Z, or I have read recently that X, Y, or Z. And I think providing that context is helpful. Okay, so for about 20 seconds, anyone who has a question, feel free to ask a question, or if you need to go get a piece of paper or open your notes tab, go for it. Okay, awesome. So now we're going to talk about hepatitis A. So for this first case, I want you to imagine that it's April 2020 and you're going to clinic and you're on the bus and you pull up in the Seattle Times and you see this article. It says King County faces 2 outbreaks at once as hepatitis A spreads amid coronavirus pandemic. And you see this interesting graph of the number of hepatitis A cases in King County. And these letters at the bottom of this graph are the correspond to months of the year. So you see that in March 2019, there were 3 cases of hepatitis A detected in King County. And now in March of 2020, there were 30 cases. And you read that between January 1st, 2019 and April 1st, 2020, there were 165 cases of hepatitis A in King County as compared to a typical year's caseload of 5 to 16. And that 50% of those people affected were experiencing homelessness. So when you get to clinic and your first patient is a 45-year-old man who's complaining of abdominal pain. And you know from chart review that he lives in a tent in Ballard and he's not vaccinated for hepatitis A. So given your awareness of the current outbreak in people experiencing homelessness in Seattle, you have hepatitis A on your differential. So at home, I want you to answer the following questions. What other signs and symptoms of hepatitis A should you be looking for? How could you test him for hepatitis A? And if he has Hep A, how will you treat him? So you'll have like 30 seconds. Okay, great. So to go through some Hep A basics. The one thing that I learned in researching this is that there's an incubation period for Hep A that can be between 15 and 50 days. So someone can be infected with Hep A and actively shedding the virus without any symptoms for up to like a month. And then the symptoms that develop are often fatigue, abdominal pain, nausea, diarrhea, fever, and jaundice can develop a little later. And if you check their blood tests, they have elevated liver enzymes up to the thousands sometimes, and then hyperbilirubinemia that can also be quite impressive. So for transmission of Hep A, it is fecal orally transmitted. And so you can imagine that outbreaks are common when people don't have consistent access to hand washing or human waste disposal, like in homeless encampments. But there have also been outbreaks in daycare centers or other institutional settings. There have been outbreaks in the MSM community, but really any community where people are having anal sex are at risk. And then food and water can be contaminated. So there have been outbreaks associated with restaurants or food distributors. And people who travel to countries where Hep A is prevalent can get exposed through food and water if there's not the same standard of water purification and hygiene practices. So you diagnose Hep A with a blood test that looks for anti-Hep A IgM antibodies, and the treatment is supportive, so symptom management and sometimes hydration if they need it. And these patients can look pretty scary if their liver enzymes are really high and they're super jaundiced. But really, it's only 1% of people with Hep A can actually progress to a fulminant liver failure, and most of them have underlying Hep B or Hep C or other underlying liver disease. So now I want us to step back from the clinical context and think about the question, why is there a hepatitis A outbreak among people experiencing homelessness in Seattle? So I have this table here that has each of the levels of this framework. And I'd love it if you would tell me in the chat or by unmuting what factors you think of that are making this outbreak happen in our community. ready to write them down. Thank you, Kayla. Access to clean water. One might say also access to bathrooms. Access basic hygiene, yes. Clean water, hygiene facilities. Lack of health literacy, yep. Yep, housing crisis. Julie, tell me more. What do you mean by that? Policies that go into it. So yeah, what kinds of policies?
Currently, it is illegal to have like rent control. It's in the state constitution.
Yes.
That has led to a lot of the housing crisis.
Yes, lack of rent control laws. Yes, zoning laws that have prevented also affordable housing. Policy, a lot of resources were no longer available during lockdown. Yes, especially, yeah, I think especially public bathrooms during the coronavirus pandemic. Yeah.
I think there's a policy limitation that's based on Hep A vaccination. Sorry, this is Ruth. So you only get Hep A vaccination if you're traveling or have some other risks. So I think people fall through the cracks if they could have been vaccinated.
Yes, I think that's almost like a policy within healthcare of our like Hep A vaccination practices. Encampment sweeps resulted in people, yeah. And I actually think, so encampment sweeps were also stopped for a certain amount of time during the pandemic. And I don't know how that affected this outbreak. Encampment sweeps, turned off water, decreased shelter capacity. Yeah. That's great. And access to preventive care. Low vaccination rate among this population. Yeah, and I think we've touched on some of the things that contribute to a low vaccination rate being difficult access to preventive care services, communal shelters over private room shelters. Thanks. Yeah. COVID crisis, job loss leading to homelessness. Yeah. Earlier in the pandemic, middle class hoarding hand sanitizer and Lysol wipes. Yeah, that's a great point. Yeah. Okay, I didn't get to write all of these down, but thank you so much for participating. And I wanted to review some of what the Seattle Public Health Department did do. So they did increase the number of bathrooms and hygiene stations. There were hotel rooms available for a certain number of people experiencing homelessness during the COVID pandemic. There were, reinforced restaurant and hygiene protocols. There was tracing to certain areas, particularly to Ballard. And then there was a vaccination campaign. I think a lot of us who are on the inpatient service were a part of really trying to increase vaccination in this population, providing educational materials and encouraging personal hygiene. And I think it's important to recognize a lot of these interventions were at the individual level. And there's a lot of what you brought up on kind of a policy and community level that have not yet been addressed. Okay. We're going to move on to hepatitis B. So your next patient in clinic is a 30-year-old woman presenting with lower back pain. So you're reading her chart that she immigrated to the US from South Sudan 3 years ago and is primary to Guinean speaking. She does not take any medications, and her past medical history is notable for chronic hepatitis B, which was diagnosed on routine screening 2 years ago. She was recommended to receive repeat liver tests and HBV viral load monitoring every 3 to 6 months, as well as follow-up with hepatology for additional workup, but she has not showed for her appointments in the last 2 years. And the questions I want you to consider are: what are ways that this patient may have been exposed to hepatitis B? And what barriers to follow-up are important to explore with her? I'll give you 30 seconds to think about those. Okay. So before we get into the answers to those questions, I want to review some hepatitis B epidemiology. So it's estimated that 2 billion people in the world have evidence of Hep B infection or exposure. And considering that there are like 8 billion people in the world total, that's like a quarter of the Earth's population will be exposed to this virus. And the highest prevalence of chronic Hep B is in sub-Saharan Africa and Western Pacific countries. And so if we look at this map over here, that darkish green brown represents the highest prevalence, which is greater than 8%. And that like next lighter green is high moderate prevalence at 5 to 7%. And over 800,000 people die annually of hepatitis B complications, and those are often cirrhosis or hepatocellular carcinoma. It is the #1 underlying condition that leads to liver cancer in the world. And in thinking about transmission, this is a figure that the Hepatitis B Foundation made and explaining hepatitis B transmission. So it can be transmitted through blood or semen. And in getting to blood-borne transmission, it can happen through pass from mother to child during birth. So that's a vertical transmission. And then it can be transmitted through household contact or sharing household items like razors, toothbrushes, etc. And in Hep B endemic countries, many people are exposed as children, like between the ages of 1 and 5. And that is mostly through living in a community with people who have high Hep B viral loads. And this was surprising to me, but then I think about, how often kids are like scraping themselves and cutting themselves or putting everything in their mouths where there's often some mucosal breakdown. So that's a common way that people are exposed. And then in more obvious percutaneous exposures are through tattoos and piercings. And then through intravenous drug use and sharing needles. This is the most common mode of transmission in the United States. And then there can be healthcare exposures, so that can be through untested blood products or through healthcare workers who are exposed to blood often are at risk. And then you can be sexually transmitted. So it's important to remember that the age at which someone is exposed to hepatitis B is directly related to how at risk they are for getting chronic Hep B. So if someone is perinatally exposed, then you have a 90% chance of progression from acute to chronic Hep B. If it is required between the ages of 1 and 5, that rate goes to 20 to 50%. And then if you're exposed as an adult, that rate is less than 5%. So if we look back at the places where chronic Hep B is endemic, people are mostly getting exposed through vertical transmission or through household contact while they are kids. And I think another thing I want to point out is that probably why we have low rates of Hep B in the United States is there is a universal vaccination program where if any babies who are born in a hospital before they leave the hospital are offered a Hep B vaccine, and other parts of the world are still developing their vaccine protocols for Hep B. Okay, so talking about Hep B in the United States, and knowing those modes of transmission, then vulnerable populations are people emigrating from Hep B endemic countries and their children, people who use IV drugs, people with multiple sex partners who don't use condoms, healthcare workers or first responders, and people who are incarcerated. And that is really people who are at risk of being exposed to Hep B. But as we just discussed, most of the chronic Hep B in our country is from people who are born outside the United States. So 70% of chronic Hep B in the US are in foreign-born individuals. And that's why the CDC recommends screening patients who emigrate from countries with greater than 2% prevalence of Hep B. And this is a long list of countries. So really, if you have a patient who is born outside the US, I recommend just looking up whether they should be screened for Hep B. And I also just want to be clear that anyone on this vulnerable populations list is recommended to get Hep B serologies to look for infection or confirm immunity. But I wanted to point out the CDC recommendation specifically given our case and the focus of our conversation. So now to zoom out again from the clinical context, I want to ask the question, why are there low rates of chronic hepatitis B detection and linkage to care in the African immigrant population. Does anyone have ideas? And Sylvia, what is the rate of vertically transmitted Hep B progressing to cirrhosis in infants that get the vaccine? That is a question I don't know the answer to off the top of my head, Sylvia, but I will make note of it. Thank you, John Cho. Rights are law. Okay. So do people have ideas about what factors are contributing to us not getting people linked to care? Low rates of screening. I think that is a healthcare factor. And Terrence says language barriers for sure. Financial resources for sure. Caitlin or someone else, tell me more about, yeah, health insurance access. Yeah. And that's a little bit of a policy point of sort of like how hard it is for people, especially who immigrate to this country, to get adequate health insurance. A little bit of it's kind of an economic force actually of health insurance. Transportation, great. And I think one thing you're getting at there, Zainab, is access, is that we still largely expect people to come to us for this frequent screening for a condition they have no symptoms of, but we have told them they need to come every 3 to 6 months to us for screening and care. Mistrust of systems and doctors. Yeah, and I think my friend Anna always, whenever I say mistrust, always asks like, but what have we done to not be trustworthy for these populations? Generally just not having time to go to the doctor. Yeah. And I think in this sort of like high burden of screening and the sort of come to us expectation. Yeah, not having time. Yeah. Not having time to come during work hours, which is the only time we allow people to come. Yeah. I also wonder about, sometimes the quality of our translation services. I think we often don't have great translation services access for people who speak African dialects. Other health priorities are more important, or that are more acute. Yes, I still think it's amazing that, we're expecting people to have a lot of follow-up for a disease for which they don't have any symptoms. And I personally would also not have a lot of urgency in that situation. Yeah. I think we also haven't talked to some about, I think generally in our community, stigma around communicable diseases in general. I think probably a lot of us have a bias of Hep B is among people who have risky sexual practices or are using IV drugs. And that can make it hard for people to feel welcome or feel like they can talk about it or ask questions. Yeah, healthcare worker awareness about who should be screened is tied to that stigma too. Yeah, low rates of awareness. And I think some of that low rates of awareness is within these communities. Has recommended vaccination in kids for a long time. So war and other barriers. Yeah. Policies include immigration policies that impact healthcare availability and utilization. Yeah, and I think it also affects how welcome people feel in our country when we have immigration policies that criminalize people who have come to our country not through all of the right ways. The administrative burden of immigrating to our country, and especially getting insurance if you've immigrated to our country. And I think that probably, trickles down to not feeling welcome in the healthcare space. I think some other things, I read a qualitative article that talked about, in certain parts of the world, preventive care is not a concept that people have the privilege of having. And so this idea of following up frequently for something that may or may not lead to something down the road is something that can be hard to communicate. Yeah. Anything else? Impacts immigration population more. So there may be less urgency in policymakers. Yeah. For sure. Okay. So I'm glad we mentioned screening because there's actually some research going on at UW on this issue. So there's a study called Hepatitis B virus screening in primary care among persons from HBV and endemic countries in the UW primary care clinics from 2016 to 2019. And we have one of the authors of this study with us today. Ermias is going to tell us about this study and what he found.
Thank you, Annie, for inviting me to share the findings of the study. So we assessed the adherence to the CDC recommendation for screening hepatitis B among non-US born individuals or people coming from intermediate and high prevalence area. As you know, CDC revised the recommendation and lowered the cutoff from 8% to 2% in 2008. So our study is a retrospective cohort analysis of the electronic medical record system. We approached the electronic medical record system from all UW healthcare primary care clinics, and we tried to identify people from intermediate and high prevalence regions by identifying country of origin, country of birth, and the primary language they use. And we took adult patients enrolled in the UW primary care healthcare system in 2016, and at least having another one visit until the end of 2019, so a 4-year study period. And then we looked into completion of any form of hepatitis B virus studies, mainly the surface antigen, but also like DNA tests or other kind of screening tests that were used in the electronic medical record system. So after excluding those patients who already were enrolled after having a test, we got like a 2,300 people who were eligible for the screening test. And it was only about 1/4 of them who were screened during this study period. And out of that, surprisingly, the prevalence of hepatitis B was found to be 5.7%, which is very high and similar number as we hear prevalence from those endemic areas. So our study shows that there is very low screening rate and high prevalence among this population. And if we are screening only 1/4 of the population who are eligible, then it means we are missing 3/4 of the cases. Thank you. If there are questions, I am here to address.
Does anyone have questions for Ermias about his study? Rebecca is asking, are there talks of having EPIC add a healthcare reminder for Hep B screening based on country of origin?
Yes, so we are recommending that there should be some kind of reminder for providers when they see this kind of patients, so that they can proactively discuss the need for a test and order it.
Yeah, and I am going to move on just so that we have enough time, but we can note these questions and make sure that we get them answered for you all. Okay, but I am going to move on to, last but not least, hepatitis C. So your last patient in clinic is a 52-year-old woman who just moved to the area from Arizona, and she wanted to talk about getting treatment for hepatitis C. So she was diagnosed with Hep C 3 years ago. She uses IV heroin daily and is not ready to stop using. And she was referred for treatment previously in Arizona, but was told that her Medicaid insurance would not approve the reauthorization. So my questions for you all are, can you offer her hepatitis C treatment if she is still using IV drugs? And what can you tell her about what hepatitis C treatment might entail? So I'll give you like 30 seconds to think about those. Okay. So I'm first going to address some of hepatitis C epidemiology. It's likely the hepatitis you have heard the most about, for good reason, as it is the leading cause of liver-related morbidity and mortality in the United States. And it's estimated that 2 million people are affected in the US. The prevalence is still greatest in people born between 1945 and 1965, but the incidence is growing among younger people who use IV drugs. So the rate of new cases and really the epidemic that we talk about of hepatitis C is within the community who use IV drugs. And there is a higher prevalence in non-Hispanic Black Americans, and that's based on NHANES and National Vital Statistics data, which doesn't even include patients who are incarcerated. So Hep C treatment. I want to stress that all patients with chronic hepatitis C should be considered for treatment. So for our patient, if she is still using IV drugs, that does not disqualify her clinically for treatment. And the treatment is direct-acting antivirals, and these were approved for use in 2014. One example is ledipasvir sofosbuvir, also called Harvoni is the trade name. There are many other formulations of DAAs, but they all are basically 1 pill per day for an 8 to 12-week course, and are over 95% effective at curing a patient of hepatitis C. I think we have all come of medical age in a post-DAA era. I think sometimes we lose sight of the fact that this is one of the greatest scientific achievements of our lifetime, at least within medicine. That the fact that we had a chronic disease that was affecting millions of people and limiting their lives. And now we have a 2-month to 3-month course of treatment with pretty low side effects that is 95% effective at curing them. It's incredible. And it has allowed the WHO to have a goal of eliminating hepatitis C in the world by 2030. And there are countries that are on track to meet that goal. Australia has a very robust government-funded DAA rollout program, and they will not have hepatitis C in Australia by 2030, most likely. And the US, on the other hand, is not on track to meet that goal. And so my question for you all is, why is the US not on track to eliminate hepatitis C by 2030? I'm hoping you can offer some ideas about that. Yes, so I think there is kind of our, just gonna say it, lack of universal health care access for all people. Lack of outreach, low screening, Medicaid coverage discrepancies. Yeah, and that is kind of a policy, like that Medicaid is a state-run program, and sort of like their requirements and barriers to treatment within Medicaid policies. Lack of outreach, I think that comes sort of in the healthcare realm around outreach and screening. Policy in Washington, PCPs can't offer DAAs, have to refer. Yes, so these requirements and sort of barriers to prescribing that for some reason don't exist for most other medicines that we prescribe. Stigma against people who use drugs, for sure. So that, I think that affects how like perceived stigma by individuals, also probably stigma within healthcare workers and within these policies. Medications are expensive. Thank you, Julie. I think that is the cost of the drug is high, and I think that drives a lot of this. And why are the costs of drugs high in America? I think that there are policies that allow for that too. I just found out that the only GI GIs, is that correct? And it is, so not an only GI specialist can prescribe it. We often, in Washington, you need sort of to have taken a course and then often to have the oversight of recommendations, but you can prescribe it. No real nationally coordinated effort as far as I know. Yeah, that's sort of for healthcare too. And why don't we have a nationally coordinated effort also has to do with the fragmentation of our healthcare system. Patients might not know about Hep C screening in the same way we think of colon cancer screening, breast cancer screening. Less screening equals less diagnosis. Yeah. Thank you, Caitlin, for clarifying that. Cost of harmony, insurance companies don't want to pay for it. If they don't have to, it doesn't make sense for one insurance company to pay money to prevent the spread of their one patient. Yes, and I think you're getting at, this is, when we talk about infectious diseases, is that we have to think of it as a population and not as individuals, but every individual has a different insurance coverage in our country. Those who are co-infected with HIV have access. Yeah, so there's some, the costs are high, and sort of like how this drug is paid for is really fragmented. Actually, people who do not have any insurance can often get coverage through, or get complementary medications through the drug company. But if you have insurance, sometimes the copay is several, tens of thousands of dollars a year. You have to have a pharmacist who is qualified. Again, this sort of like administrative burden of prescribing it is huge. Yeah, public health has not been well funded for this problem in the past. Yeah, and the kind of separation of who provides public health in our country and who provides medical treatment, limited access to clean injection supplies. And I'll also say policies, there are a lot of barriers to needle exchange that are, local policies around this. There's thankfully pretty good needle exchange resources within Washington, but not everywhere. And one of the interpersonal factors is that needle sharing can contribute to this. And I think one thing that has come up too on an individual level is that it is important for people to continue to take the drug every single day. And if you're servicing your addiction, it can be hard to have as much follow-up and adherence to that, just by the nature of addiction. But we also have in healthcare made barriers in terms of like frequent screening and labs that are required to get treated. Does the CME offer to like the UW HCV online curriculum meet the requirement for prescribing? MACA does not. Yeah, so it's still pharmacy managed. Yeah. Follow-up labs. Okay, great. I'm going to move on so I don't go over time. And I really wanted to show you all this map. So like we said, Medicaid is a state-run program. And so each state can decide what their requirements are for patients in order to receive reimbursement for hepatitis C treatment. And so in all of these states that are dark red or bright red, patients have to demonstrate 3 to 6 months of abstinence from drugs and alcohol in order to be eligible for Hep C treatment. I just want to outline that has no clinical indication for that this is purely a financial interest rather than a patient-centered policy. And that if you're trying to stop an epidemic in people who use IV drugs, that only treating people who are no longer using drugs is not going to be very helpful. So our patient was from Arizona and likely did not get her pre-authorization approved because she had not demonstrated sobriety. So there also are fibrosis score restrictions. So certain states require that you have evidence of some scarring of the liver. So fibrosis scores of greater than F2. So all of these blue states in 2014 had fibrosis score requirements. Again, there's no clinical reason why someone should not be treated until they already have evidence of fibrosis of their liver. And you can see that Washington was one of those states in 2014. And then there was a class action lawsuit in 2017 in the state of Washington, where Medicaid patients with hepatitis C sued the Washington Healthcare Authority over this fibrosis requirement, and they won. And now, as of 2019, there's a lot less blue on this map. And I wanted to leave you with that as an example of people identifying inequities and injustice within the system and doing something about it in a way that has improved care for people all over the country. So for some take-home points I want to review. Hepatitis A is spread through fecal oral transmission and is treated with supportive care. Hepatitis B is prevalent in immigrant populations from the Western Pacific and African countries. Hepatitis B transmission can occur through vertical transmission in childbirth, household exposure, intravenous drug use, healthcare exposures, and sex. Hepatitis C treatment is over 95% effective and is recommended for anyone with chronic Hep C who is interested in treatment. And hepatitis C treatment with direct acting antivirals is 1 pill per day for 8 to 12 weeks. And the social ecological model can be used to consider the obstacles to equal access to health for patients vulnerable to viral hepatitis. All right, does anyone have questions? I'm going to look back through here. Do you need overlap in prevalence and incidence on this map? Prevalence and incidence of Hep C, Ruth, I do not. That was just, those maps were just displaying requirements for HCV treatment by Medicaid in each state. Washington Medicaid did not cover HCV treatment until a lawsuit was brought against the state. Yes, thank you, Matthew Cataldo. Other questions people have? And if not, I just want to say thank you to all the people on this list who helped me with this presentation. And that is my time. Thank you all.